The following podcast is part of a certified educational activity titled The Rise of B-Cell Therapies in Relapsing MS, examining the state of the science, new therapeutic options, and patient-centered clinical decision-making, featuring Dr. Amit Bar-Or from the Perelman Center for Advanced Medicine in Philadelphia, Pennsylvania, and Dr. Ludwig Kappos from University Hospital Basel in Basel, Switzerland. Access the entire activity and complete the post-test at peerview.com/WEN860. Downloadable slides and practice aids are also available.
Hello, my name is Ludwig Kappos, and I welcome you together with my colleague, Professor Amit Bar-Or, to this presentation, which is about the rise of B-cell therapies in relapsing MS. We will try to examine the state of the science, new therapeutic options, and also ways for patient-centered clinical decision-making. So let's start, and it is my special pleasure to introduce Professor Amit Bar-Or. I've been, over the last decades, I may already say, admiring his deep knowledge of clinical neurology, specifically neuroimmunology and also immunology, and also very specifically his ability to explain to others who are not so deeply involved with immunology the basic mechanisms. And this will be also your task today, to provide the newest knowledge about the role of B cells in MS pathogenesis. So it's up to you now, Amit. I'm looking forward to your presentation.
Thank you, Professor Kappos, very much for the very gracious comments, which coming from you are a high compliment indeed. And I will try to briefly go over some of the backdrop to thinking about B cells as relevant targets for intervention in the context of multiple sclerosis. And to do so, I'll provide a little bit of an overview of the change in perspectives, which started us as thinking of MS being largely mediated by T cells, and really the emerging or evolving view, including the therapeutic landscape, current and future, has recognized that it's not just about T cells, but it's about multiple different types of cells interacting, including B cells, T cells, myeloid cells, microglia, astrocytes, and so on, and that through a variety of molecular and cellular interactions, these are involved in the pathophysiology of multiple sclerosis, which we're trying to target therapeutically, and that understanding helps us improve the discussions with patients. So this is a simplified model with the CNS in the lower right, separated by the traditional barriers from the periphery, where the immune system typically resides. And we think that activation of immune cells in the periphery, and through upregulation of a series of molecules that enable them to more efficiently cross the barrier, get reactivated within the CNS, and then bring to bear what impacts the CNS target organ involving the damage. And it is these cascades that we can think of in the context of current and future therapies. And again, while T cells had been thought of as the main mediators of the disease, the main emphasis here is that it's about interactions between different cells, and that those interactions in the periphery are almost certainly underlying the waves of inflammation involved in relapsing biology, but interactions between immune cells, and indeed immune cells and brain cells, within the central nervous system, and as part of what we now refer to as compartmentalized CNS inflammation, are thought to almost certainly contribute importantly to the non-relapsing progressive disease biology that patients experience, involving again both the immune cells that infiltrate and set up shop, but also through the interactions with and the activation of brain resident cells, including microglia and astrocytes. And so in this brief overview, we will just try to frame how we've thought over time of the different players contributing. And at the center of this cartoon, where we're considering the evolved thinking and the cellular immunology of MS, in the center, we see this concept of central nervous system or CNS-directed responses. It turns out that all of us, whether we have MS or not, have cells in our body that can recognize self-antigens, including CNS self-antigens. They exist probably for very important and very interesting reasons that we're just learning about now, but they are normally present and regulated so that they don't mediate damage. And the regulation involves, at least in part, different subsets of T cells and the balance between effector and regulatory T cells, both of which have been identified as contributing to MS. But they don't work alone. They involve interactions with myeloid cells, where the myeloid cells can shape T cells and vice versa, and hence a bidirectional arrow that we've appreciated is playing out for many years. What about B cells? Historically, the traditional view had been that they are relatively passive. They're waiting to get help from T cells, which then turn them into antibody-producing cells. And certainly in MS, we've known for a long time that there are abnormal antibodies produced and present within the CNS of patients. And that, in fact, was the early rationale for trying to target B cells therapeutically in MS. It turns out that is highly effective, as we'll be hearing more about in a moment, but that the reason has not to do with removing bad antibodies from the CNS, rather the capacity of B cells, different subsets with different functional response profiles, well beyond the antibody potential, to also interact with, regulate the autoimmunity, and talk back to both T cells and myeloid cells. And it's this cascade of interactions that we try to break therapeutically with different approaches. We can think of anti-CD20 as selectively removing broad populations of B cells from the circulation and some small populations, as we now know, of T cells as well. And we can also think of future therapeutics such as Bruton tyrosine kinase or BTK inhibitors that are now understood to work by both targeting B cells as well as myeloid cells and raise the prospect of impacting the biologies both in the periphery and within the central nervous system. And so back to our original cartoon, with this in mind and the different biologies contributing to the different aspects, the relapsing biology and the progressive biology, we will segue to a more focused discussion about the role of anti-CD20 antibodies and beyond in relapsing MS to clarify options therapeutically in the context of the expanding knowledge and the expanding treatment landscape. And with this, I turn back to my colleague and friend, Professor Kapos.
Well, thank you, Amit, for this really very concise and actual summary of the rationale behind B-cell targeted therapy, especially with anti-CD20 antibodies. And as you already mentioned, one of these antibodies, anti-CD20 antibodies, was used several years ago by the group in San Francisco in the first proof of concept controlled study. This is Rituximab, and perhaps it's good to provide a short comparison or overview of what kind of antibodies are available that target anti-CD20 according to their production and their similarity to the human molecule. We differentiate the so-called chimeric with a part that derives from the mouse and a part that is human. Then the more similar to the human molecule, humanized antibodies like ocrelizumab, and then fully human molecules without any rodent constituents, and then the so-called glycoengineered that have not yet been approved for the treatment of neurological diseases yet, like Rituximab, which is still in phase 2 and phase 3 studies in multiple sclerosis. This has mainly an impact on the immunogenicity of these antibodies, so the amount of immune reactions to the antibody itself and the immediate reactions at the time of infusion of the compounds. But now, for why did we enter this area and why does it have so much of interest and so much of impact on our thinking about the pathogenesis, but also on daily management of MS patients. This was the first seminal proof of concept study done with Rituximab, and which showed an immediate or nearly immediate, after already 4 weeks, appearing effect on inflammatory activity in relapsing remitting multiple sclerosis, together shown on MRI, but also on with the effect on relapses. Rituximab has not been followed up with controlled studies for different reasons, but was available because it is approved for other indications and has been widely used in some countries for the treatment off-label. And several studies have indicated that it has an effect and that it is well suppressing not only inflammatory activity, but has also in more advanced cases of MS in progressive forms, that it may have also a delaying effect on disability progression. Just as an example, a paired comparison study of off-label use of Rituximab, where you see in these diagrams that the pace of progression was delayed in those patients who were treated with Rituximab as compared to other treatments. One further advantage of this off-label use of especially Rituximab in the area of MS, relapsing and progressive, is that we now have a long-term experience about the side effect profile. And what has emerged, especially from the Swedish group that has also published extensively on these open label studies, is that over the years the risk of infections is indeed, as compared to other treatments or untreated MS patients, increased. And this is something that we need to keep in mind when we discuss the further data on efficacy. Data on efficacy, or sustainable and more convincing data on efficacy, have been first assembled through 3 controlled studies. As you know, 2 of them in relapsing MS, first after a proof of concept study with ocrelizumab, and then with 2 large parallel studies in relapsing MS, Opera 1 and 2, as compared to interferon beta 1a 3 times per week, and Oratorio, the 3rd study in primary progressive MS, where ocrelizumab was compared with placebo. And what we see, the results are well known, I will just show them very briefly here, was a very impressive effect on the number of relapses, with a nearly 50% reduction of relapses in the Opera 1 and 2, but also a statistically significant effect on the rate of disability progression or sustained worsening of impairment, and a more impressive effect on inflammatory signs in MRIs, in gadolinium-enhancing lesions, as shown here on the left corner in the 2nd line, but also an effect already seen after 1 year on the rate of volume reduction that was reduced in both relapsing remitting trials. In progressive MS, the effects are less impressive, but still statistically significant and a step in the right direction. And you see here again that there is a delay of disability progression confirmed after 12 and 24 weeks, and there is also an effect on T2 lesion volumes, and somewhat later separating from the placebo group an effect on brain volume loss over time. So after 2 years, the effect is statistically significant with a lower rate of volume reduction in those patients who received ocrelizumab. More importantly, in my opinion, are the long-term observation extensions with open label treatment, switching interferon beta 1a or placebo patients to active treatment with ocrelizumab. And these studies that are still continuing, but now in the 6th or 7th year of follow-up, have first of all quite a good retention rate. So we do not only select the few responders, but the majority of the patients who were initially randomized in the controlled phase of the trial. This is an important part for the interpretation of the results, and they show a sustained or perhaps even somewhat increasing effect on the inflammatory component of the disease. Here in relapsing disease, the annualized relapse rate, which translates to 1 relapse every 8 or 10 years, which is, I think, really a very impressive effect in the long term, and also a sustained difference or advantage of those who started early with the treatment with anti-CD20 antibody over now more than 5 or 6 years. So the difference that was obtained in the controlled phase continues, although in both groups the disability progression is reduced, as you see here in this diagram. This is another analysis that was recently presented and which shows the time to something more easy to understand. So the number of patients who exceed EDSS of 6.0 confirmed for more than 48 weeks, and you see that again there is an advantage and in the first controlled phase, and this is retained over the next phase, the long-term follow-up, where the curves have a more or less parallel course over this time. So the same effect, but the initial effect obtained in the controlled phase continues to persist. So there is still a significant difference in the number of patients who reach this level of EDSS 6 or more. What about safety? Regarding safety, I had already alluded in the context of rituximab that are one of our main concerns is an increased rate of infections. This was up to now not really materialized in the controlled setting and in the GCP according to GCP follow-up in the older studies. There is a slight increase over time regarding infections if you take also into account the somewhat longer intervals of observation or frequency of observation. And fortunately, there is not an overall increase of the rate of malignancy. So the concerns that was initially raised for a higher preponderance, higher incidence of malignancies has not been confirmed up to now with a safety follow-up of 6.5, now in the meantime 7 and more years. Regarding convenience, there was a recent presentation that shows that the duration of the infusion can be reduced to 1 hour instead of 2 hours, and this is something that has also been now officially approved both in Europe and in North America as a way to apply these infusions. So the infusion reactions were not significantly different with the shorter infusion time, and this is certainly something that adds to the quality of life and reduces the burden of the infusions. What is also interesting that in addition to the effect on atrophy rates or reduction of the brain volume, we also see normalization with this treatment, especially in the relapsing MS population, on the NFL neurofilament light levels. As you know, neurofilament lights are a specific marker of neuroaxonal damage, and it looks, based on these data that were also recently presented by my colleague Amit as a first author from the OPERA studies and also from the oratoria studies, that there is a tendency to normalization and to shifting the curve to the left, so where you would expect also the normal population to be during the treatment with ocrelizumab. Another important piece of evidence that shows that there is an effect also on tissue preservation the recent analysis of thalamic volume loss that, similar to clinical progression, was also moved to the positive, and was also in those patients who had higher levels of NFL as a marker of neuroaxonal baseline NFL levels. So the effect was seen both in those with high and with low baseline NFL levels. This is the short account of the so-called casting trial, where the 2-year NIDA rates, so the classical 3-part NIDA, and you see that in this representative population of patients with relapsing remitting MS, there was a high rate of patients who fulfill the NIDA criterion. You see more than approximately 3/4 of the patients after 2 years had still had this criterion of no evidence of disease activity as defined by MRI, which is the most important driver of this outcome, and relapse rate and clinical progression. I think in the interest of time I will skip this part about the CORDS trial and proceed to the increasing tendency also to expand the spectrum of indication of ocrelizumab, that it is more and more considered to use it, first of all, earlier in the disease, and it's something that we will come back later on also, and also to use it in specific situations, for example, when switching from other treatments, be it natalizumab or be alemtuzumab, or of course the more oral compounds, and we are gaining an increasing number of observations, more or less systematic, that allow or provide a better basis also for everyday decisions. Now, if we see these quite impressive effects of anti-CD20 already starting with rituximab, then even better with ocrelizumab, is there space for further improvement? And this is something that was analyzed and further explored for ofatumumab. As I had already mentioned, this is a fully humanized antibody that, in contrast to rituximab versus ocrelizumab, which bind to a very similar part of the long extracellular loop of CD20, it does also bind to the shorter loop, and if this has implications for the efficacy or the selectivity of the effect is still open for discussion. One other aspect that has to be taken into consideration for ofatumumab is that it is given subcutaneously and so does not afford the 6-monthly infusions in a center, but can be administered by the patient themselves after a first initiation phase with an every 4-week subcutaneous injection. So ofatumumab, after phase 2 studies that were also spearheaded by my colleague Amit, entered phase 2, also in a very similar design as for ocrelizumab in the Asclepios studies, to parallel studies, but this time not comparing with interferon, but with teriflunomide, an oral compound approved for the treatment of relapsing multiple sclerosis, which has, in my opinion, the key advantage that it can also be much better blinded. So it has not the substance-specific side effects of interferon, and therefore can provide a setting that is really double-blind, and therefore you can better recognize the real effect of the drug. You do not have to reduce it by a placebo rate. And the results are also very impressive. Were published in the New England Journal of Medicine. Here a short summary of the overall result and effect on the annualized relapse rate against teriflunomide, more than 50% reduction, and also statistically significant reduction of 3 and 6 month confirmed disability worsening by approximately 35 or 30%, which is also a very good range as compared to other treatments that are now available for multiple sclerosis. We also see this nearly complete effect on inflammatory activity, on both gadolinium enhancing and new or enlarging T2 lesions. We see, but here in contrast to the results in the ocrelizumab trial, we don't see a statistically significant difference to teriflunomide. As you may know, teriflunomide had already in a blinded secondary analysis of the one of the pivotal trials shown a clear-cut effect on brain volume change against placebo, and the effect, at least over 2 years, of the two compounds was very similar. It was therefore especially interesting, and please look to this part on the lower left corner of the slide, that in this trial, this was the first phase 3 trial where neurofilament light levels were prospectively chosen as an important secondary outcome of the trial. And you see that that there is a statistically significant difference. There is only a slight reduction with teriflunomide, with the gray line here, but already after 6 months, starting with the 3rd month, but then after 6 months, a reduction, a significant and clear-cut reduction toward normalization in the neurofilament light levels in those treated with ofatumumab. This discrepancy between brain volume change and neurofilament light levels is certainly something that needs further interpretation with additional studies. The relevance of neurofilament light levels in the blood regarding other outcomes that are connected or indicating tissue damage or tissue destruction is shown in this slide, where you see that patients with low levels and those with high levels have different probability of and different amounts of enlarging T1 hypointense lesions per year, as you see here. And fortunately, the effect of the drugs or the advantage of ofatumumab in reducing the rate of new T1 lesions or enlarging T1 lesions over time was similar across both groups. So this slide shows both the effect of the drug but also the relevance and the connection of neurofilament light levels to these outcomes, and interestingly enough also to the outcome of brain volume loss, so that neurofilament light are related to the risk of brain volume loss, and that but nevertheless, as I already mentioned, the effect of ofatumumab on this outcome on brain volume loss was not visible within 1 or 2 years. You know the discussion about the pseudoatrophy and so on. Maybe we can take this over with in the part where we answer your questions. A subgroup analysis has shown of the Asclepios trials that treatment-naive and early relapsing MS patients who were a considerable proportion of the overall Asclepios population, approximately 1/3 of these patients, that they have an even stronger effect of the drug. As you see in this slide, the effect of ofatumumab with this subcutaneous dosing is very reliable. So we have a nearly immediate drop of B-cell counts, which remains at the low expected level, and interestingly enough also not different across different body weight groups as shown here in this diagram. So we seem to be in a ceiling area where this dosage is sufficient across all weight classes of patients, and this would be certainly interesting to further explore this dose relationship and see, especially at the moment we don't have a reason to do that, but also reacting to perhaps long-term adverse events, if this can be adapted or reduced in some way, but this is something where evidence is still lacking. I will not expand too much on the side effect profile of ofatumumab. It's very similar to what has been expected for anti-B-cell monoclonal antibodies. No new signals, and especially local reactions are not a problem. Regarding systemic reactions that accompany at least the first infusions in patients and also require a specific treatment, this is less of an issue with the subcutaneous injection. So the overall tolerability and therefore also the burden for patients and perhaps their any constraints regarding their willingness to use this drug seem to be even lower with this compound. What was interesting was if, according to the neurofilament level at baseline, which is a prognostically worse indicator, if we see differences in the effect of the drug, and this was on both the MRI measures and the clinical measures, the effect was clear-cut and still robust across groups of serum NFL level. That was data that were presented at the last ECTRIMS and ACTRIMS conference by my colleague Dr. Kuhle. Just a short remark, because it's not yet so close to clinical application outside of clinical trials. The results with Rituximab, there was the results of a phase 2 multicenter study were presented, which also show an effect on, as expected, on the MRI outcome. More data are at least not available to me. Here you see a very similar effect over, of course, now only 48 weeks on the rate of patients who have no evidence of disease activity. At the moment, there is a phase 3 study ongoing with this compound, and we are looking for, again, comparing with teriflunomide, which seems to be the favorite comparator for actually going on studies in relapsing MS. And we are looking forward to the results that are expected in a year or so from now. Let me finish this overview with an short review of something that was already mentioned by my colleague Amit Bar-Or, the possible role of BTK inhibition, which seems to combine a similar effect on B cells, on the B cell activation, B cell activity, not a depleting therapy, but reducing functionally the effects of B cells on one side, but also of CNS microglia. And at least some of these compounds pass quite easily as small molecules into the CNS and are expected to exert also a direct effect on the more compartmentalized immune response in the CNS, therefore perhaps opening a better window of effect in the progressive and perhaps later phases of the disease. There are already some encouraging first results from phase 2, first with Fenebrutinip, presented by Javier Montalban and also published. You see the higher dose of Fenebrutinip had a significant advantage as compared to both placebo and dimethyl fumarate in this phase 2 study that is now extended and seems to confirm the results also over week 48 as presented by Dr. Montalban. So the open label extension seems to confirm and enhance the positive message of the original phase 2 trial. Based on these results, there is an ambitious program with again two phase 3 studies in relapsing MS, and also soon starting study in progressive MS with this compound. The second compound that has also presented data in a dose finding and proof of concept phase 2 study is Fenebrutinip. And you see here the somewhat complicated dose finding design of this phase 2 study, which is very similar to the phase 2 study of Siponimod. And you see that the effect with different doses of this compound on the primary endpoint, new gadolinium enhancing lesions, was quite impressive, and a clear-cut and statistically significant reduction of these and also T2 new or enlarging lesions. And based again on this phase 2 study results, phase 3 program in relapsing MS and also in progressive MS was initiated. Last but not least, a study with Fenebrutinip, which is a reversible BTK inhibitor with an with a high availability within the CNS. And there is one study that, is devoted to the effect in relapsing MS as compared to teriflunomide. And another study that I think is quite interesting, especially with the rationale that we discussed already, where in primary progressive MS it is directly compared with ocrelizumab. So we see if these advantages that theoretically would be expected and based on experimental and in vitro studies would be expected, if these will materialize. And this is certainly a very interesting study that will allow, in any case, independent of its outcome, important provide new evidence and new stuff for thought and further exploration also in the experimental design. So what are still open questions? I cannot be comprehensive enough for that, but some of those that I find important is how do we define partial or non-response to B-cell directed anti-CD20 therapy? You know the discussion about progression independent of relapse activity. Is that a non-response, and how can we address that? BTK inhibitors perhaps the answer, or even a higher dose. As you know, there is a study now ongoing on just starting on that. So is complete depletion necessary? So the other direction would perhaps a lower dose be also more similarly effective but more sustainable over time? Is there a certain time point where we should de-escalate or combine treatments with other treatments? And as already alluded to, targeting the more compartmentalized immune response, the role of microglia and other factors in the CNS. What is the perspective with B-cell directed therapies, and where is it necessary to combine this treatment with others? So let's now hand over to my colleague and friend Amit Bar-Or for the more practical part of the discussion of individual cases.
Thank you, Professor Kappos, for a comprehensive and updated overview of the data that stands behind targeting B cells in the context of MS. For the case-based analysis, we will focus on the two approved anti-CD20s, ofatumumab and ocrelizumab, and you had heard from Professor Kappos a comparison of many similarities between them, but some important differences that include the dose regimen, including the mode of administration, of course, ocrelizumab IV and ofatumumab sub-Q, with the ofatumumab being administered monthly versus every 6 months for ocrelizumab. Ocrelizumab is requiring the pre-medication, which is not something that is necessary for ofatumumab, and as far as the administration location, ofatumumab in principle could be administered anywhere, and ocrelizumab is administered in infusion centers, physicians' offices, but also more and more so in the home environment as well. In the context of thinking of patient decisions and discussions around therapeutics, of course, we have in the backdrop the issue of SARS-CoV-2 virus and COVID-19 complications, raising issues specifically about B-cell targeting and anti-CD20. We do know from the phase 3 trials of ocrelizumab that there is some small percentage increase in typical run-of-the-mill infections such as upper respiratory infections, nothing unusual, but still a slight increase. We also know that prolonged use of ocrelizumab over several years may result in some people in decreases in the IgG levels, which has been associated in a small fraction of those individuals with a higher risk of more serious infections. And in the context of COVID, The one paper by Sormani et al. With the Italian experience suggested that anti-CD20 antibody treatment may put patients at higher risk. There were other studies that did not show the same. This remains of interest to the community, and it doesn't preclude there being some added risk, but at the very least suggests that if there is, it is not a particularly high added risk. And then the question of vaccines and the efficiency of the vaccine response has been addressed formally for ocrelizumab with other vaccines in the Velocis study, and it's clear that patients on anti-CD20 who receive vaccines, and we would fully expect also for the COVID vaccines, will see an attenuation of their immune response, particularly the antibody response. But in spite of the blunted response, there nonetheless is a response, and many, not most patients, are expected to be protected. So it still is absolutely worthwhile using the treatment and vaccinating when the treatment is being instituted to patients. We will turn now for the first patient, and I will present this to Professor Kapos, and we'll look forward to his thoughts. Patient one is Tristan, and he's a 29-year-old gentleman with a new diagnosis of relapsing remitting multiple sclerosis. He presents with ascending bilateral leg weakness over a week, as well as with some concentration difficulties, fatigue, and a background of depression. His MRI shows quite a heavy burden of disease, many which are also gadolinium enhancing, and he comes in again as a newly diagnosed individual who is treatment naive. Professor Kapos, what would you consider in this context from a therapeutic discussion standpoint?
Well, thank you. I think this is really a typical situation in an MS clinic, but perhaps also in individual neurologist practices. Nowadays, I would certainly also offer an anti-CD20 and B-cell depleting therapy to this patient. The high burden of MRI lesions is an indicator. I would perhaps also consider, if available, neurofilament light levels for this patient, but even independently of that, I would certainly consider a treatment with an anti-CD20 antibody.
Indeed, thank you. And indeed, we have been seeing more and more information coming out from studies suggesting that getting started earlier on high efficacy DMTs may be beneficial as compared to starting with a lower efficacy therapy in terms of long-term outcomes. And those who start with lower efficacy therapies tend to not catch up in a sense on what they've already lost. And you identified some of the features that would make anti-CD20 a consideration in this individual. How would you say that the current environment in the context of the COVID pandemic influences your thinking about perhaps managing patients more generally, but more specifically in the context of the anti-CD20 therapies?
At the moment, I wouldn't see sufficient evidence to change my attitude towards that. I would feel more comfortable if this patient could be vaccinated before starting treatment, but otherwise it wouldn't have an influence on my choice.
And so you made the important point of trying to get people vaccinated, including, if possible, with a COVID vaccine prior to initiation of therapy, but not disrupting ongoing therapy necessarily, and certainly considering the better control or full control of disease activity being an imperative that would not preclude people being treated in the face of the COVID pandemic. Can you comment on whether we've heard some groups thinking of stretching out dosing intervals when thinking of the 6-monthly infused ocrelizumab to perhaps allow more B-cell return for a more effective response? Is that something that you've been practicing?
Actually, I'm not in favor of that as long as we don't have more arguments. There is, of course, the experience with Rituximab, where the group in Sweden has extended the intervals and describes in an uncontrolled setting a very similar efficacy. So this opens the window towards this direction, but there are also other data from the ocrelizumab studies that point to an effect of the full dose on disability progression that even is less in people with a higher body weight or body mass index, and therefore I I'm quite reluctant to change the intervals or the dose in patients with relapsing MS. In cases as in progressive MS, where the overall effect is not as pronounced, the balance is not so much driven by efficacy only, by very impressive efficacy. This has been considered, and I must admit that we have different attitudes also within our group in this respect.
And this raises the important point about thinking differently, perhaps about different patients in terms of this consideration. And those who may be with primary progressive MS and perhaps older and maybe with more comorbidities, there, of course, there's also more of a concern in terms of getting the SARS-CoV-2 infection and COVID-19 complications. I'll transition to the second patient, Sharon. She is a 57-year-old woman with relapsing MS. She was diagnosed close to 20 years ago and is now on natalizumab. She tested positive recently for JCV antibodies with a titer that suggests one needs to move on, but she's been clinically and radiologically stable. So what would your considerations here be?
Yes, our attitude in our center is to switch away from natalizumab when patients develop JC virus antibodies over a certain level. So the question is what drug to take, and I would make this also, this depends on the previous activity, which is an indicator of the risk of resuming activity after stopping natalizumab. So if this was really a high activity patient who was stabilized during treatment with natalizumab, then my first choice would indeed be anti-B-cell therapy, an anti-CD20 monoclonal antibody. In patients with lower activity before they started natalizumab, also an oral drug, especially fingolimod, would be one option. The second question that is practically relevant is when to start, and I would start with the therapy within 4 to 6 weeks, the latest, from the last infusion with natalizumab.
Excellent points. And you have made the point that you'd consider anti-CD20 in this context as well, in a sort of context-dependent way. May I ask, Sharon is 57. If she were 67, would that change your view? So age and considerations around immune senescence, or if she had a history of let's say, breast cancer with a complete mastectomy and complete remission some 15 years ago?
Well, these are really difficult questions, and I think the surface on which to move is quite slippery when trying to answer. I think the criteria of previous activity when she started natalizumab and the features of the disease in this respect would be important to consider. Additional factors like neurofilaments under the therapy, atrophy over time, even if not well quantified, would be points that I would consider. In general, with older patients, I don't see so much of a hesitation to use anti-B-cell directed therapy. I would not really change my attitude.
So I very much share those thoughts, and we, if there's any suggestion of focal inflammatory disease activity or relapsing biology, we would not hold a person's age against them in the sense of being potential candidates for anti-CD20. So thank you for those comments, and we hope for the audience this brief discussion of anti-CD20s, clinical decision-making, and with the backdrop of COVID will facilitate some questions and answers. For me, I should say that in general, a takeaway is that we've learned a great deal more about the immune pathophysiology of MS and the rationale for targeting B cells, which is quite compelling. In the past, we used to think that if you hit the immune system harder, you increase the risks. And I think with the anti-CD20s, we found treatments that are highly effective and overall quite safe. And that really is changing the way that we think of treating people earlier and with more efficacious therapies. Any particular takeaways for you, Professor Kappos?
Well, difficult to add something. I think that's for me also the key conclusion and the positive development with anti-CD20, that we have the first treatment that seems to be affordable and very effective. We had also even cytostatic agents were quite effective, but with a high burden and risk. And this seems to be the first treatment where the balance is much better. And I think that's the key advantage of this therapy. So this opens, of course, a better perspective for people with MS in different stages of the disease, but also then makes us ready for the next developments with a new generation of compounds that perhaps fill also the gaps that are still existing.
And we have received a good number of questions in our inbox, which we would like to try to address for the audience.
Yeah, it is still about the timing of vaccination in ofatumumab patients. In Ocrevus patients, we usually recommend to do the vaccination very close to the next 6-monthly dose. With ofatumumab, you could take a similar approach and ask for the first vaccine dose to be given shortly before the next dose is there. You could also consider to skip one dose and to be more on the safe side regarding vaccination efficacy. Regarding side effects, I don't think anything disturbing or problematic can occur.
Yes, I would agree with that. I don't think that there's a safety consideration. The question is there something that one might do to enhance the vaccine response? And I think that the data on reconstitution, which is limited, but nonetheless suggests that it takes a while for B cells to come back, would suggest that it doesn't make much of a difference, and waiting or not waiting may not have a big impact. There may be some rationale to wait till the next dosing cycle, but one also would need to try to avoid deeper depletion with repeated anti-CD20 to enable the best B-cell T-cell interactions for the vaccine response. So we don't have data on this, and it would be very useful to have. I agree with you, it's not a safety consideration, and what we recommend to patients, especially at a time that availability of vaccine is still limited, is to get vaccinated when you have the opportunity, when you're offered that opportunity, because you may end up going to the end of a list and not end up getting the vaccine for some time longer.
Yeah, I fully agree. We try to put our patients who plan to start with an anti-B cell therapy in front of the list, but this is not always feasible, of course. Yeah.
Correct.
There is another interesting question and about indication of or indicating anti-B cell therapy in patients who are oligoclonal band negative in the CSF. Do they still benefit? Amit, could you comment on that?
That's an interesting question. In spite of many years of research, we still don't fully know what the oligoclonal bands and the abnormal antibodies in the CNS in patients actually target and what they mean. And we think of them perhaps more as a biomarker of compartmentalized ongoing inflammation. Certainly there are therapies that are very effective at limiting relapse biology without impacting oligoclonal bands. There's some early data, Martin Weber involved, in suggesting that some immunoglobulin changes and oligoclonal band changes may be seen with anti-CD20. It's a little early to conclude that that's the case. But if one were able to eliminate oligoclonal banding entirely in patients with MS, one would think that that's a prospect of perhaps having impacted CNS compartmentalized inflammation as well, that we think may be relevant for not just relapsing, but also progressive disease.
So you would still expect a benefit in patients who are oligoclonal band negative with a clearly or otherwise not disputable diagnosis of MS?
Correct. If we think the diagnosis of MS is correct, then certainly from a relapse biology standpoint, which we think involves cell interactions in the periphery, and the benefit is reflecting a peripheral effect of the anti-CD20s, presence or absence of oligoclonal bands should not have an impact.
Yeah, then there is a bulk of questions about the comparison between ocrelizumab and ofatumumab. One is about the differences of pharmacodynamic response between these two compounds, if this has an impact on the choice, and if it is really important or not.
I think, to me at least, we don't yet have the data that would inform us on the choice between them. I do think that there's undoubtedly a difference in the pharmacokinetics of sub-Q versus IV administration. The question is, what is the impact, in fact, pharmacodynamically within the tissues, both in the periphery and possibly within the CNS? The IV administration will result in a higher peak initial dose, which is relatively transient. Might that be associated with deeper penetration into tissues and including perhaps the CNS as compared to a lower concentration? On the other hand, the sub-Q administration, which is administered elsewhere and will not be lost as quickly as the IV, may have the capacity of penetrating tissues, both periphery again and CNS, on the basis of being present for a more extended period of time, not so much the sharp peaks, but a more persistent concentration. So we don't really know, and one would like to see some data about the concentrations achieved within the CNS compartment. I realize this is also a question that people have raised in terms of the merits perhaps of considering one over the other in the context of CNS penetration, and we really don't have that data yet, but it would be very interesting to have.
Yeah, fully agree. Any questions that you have selected, Amit?
Yes, so I will ask first, there's a question here about is there ever a time when you would stop DMT after long-term stability and increasing age, particularly for anti-CD20s?
Yeah, that's, I think, a question that we cannot answer at this time based on evidence. My personal attitude is to continue treatment as long as it is well tolerated. In a patient who is, from the point of view of MS, stable and has complications that interfere with her quality of life, then of course I would consider to extend the intervals, and we have done this several times or repeatedly with off-label use of Rituximab before approval of ocrelizumab. In the same rationale, using the same rationale as our Swedish colleagues who did that for some time now. But as I mentioned, this is not evidence-based, and therefore I would only do that if I see any upcoming or ongoing adverse events that I assume could improve with an extension of the intervals.
And somewhat related to that, Ludwig, if you have a patient on B-cell depleting therapy who develops a malignancy, the malignancy is treated, completely resectable, this person still has active MS, would you keep them on the B-cell directed therapy or consider switching them?
That's again a question where it's very difficult to find the right and evidence-based answer. Yes, in most cases, again, if there is this has been active disease before, I would consider or discuss, of course, with the patient that perhaps the immune response to the tumor may be reduced, but I would rather go for continuation of the treatment.
Thank you for listening. Download materials and complete the post-test for instant credit at peerview.com/WEN860. This activity is supported by an educational grant from Novartis Pharmaceuticals Corporation. This activity is accredited by Medical Learning Institute, Incorporated. This activity is developed with our educational partner, PVI, Peerview Institute for Medical Education.